Good morning, everybody. Not the evidence-based that I'm going to talk about for safety and quality, but other evidence-based tells us that one of the worst things that we can do for our health is what we've all been doing for a minute, which is to sit down. Before we all stand up, if you're able, this is totally unplanned, but as we stand up, if you'd like to and if you're able, I want to get a sense not only for myself, but for each of us in the room. Michael mentioned this is going to be an interactive presentation. So kind of what our knowledge base is for patient safety and healthcare quality. This is a safe space. There is no judgment. We're not reporting out this in any research way, so let's not overthink the categories that I'm going to talk about. But we're going to sort of roughly, as we stand up in order, if you would, indulge me in this. If your job is, we're going to go into maybe 4 categories. Just kind of did these while I was finishing my coffee. If your job is primarily about patient safety and quality, so maybe 75% of your mental energy is spent, on safety and quality. You're a quality leader, maybe that's in your title. Again, it's primarily your job. Would you go ahead and just stand up? Again, the main purpose is to stretch. So that's terrific. So we've got, I'm looking at maybe a third, half of the room. And again, use the opportunity to get the physical benefit out of this. Next category, if your job is, if safety and quality is a substantial part of your job, let's ballpark it at 25 to 75%, where you're maybe one of the first ones to step forward for a committee that, but it's not necessarily your primary job. So we're getting a lot more folks from that, a few more folks. And then if you're anybody else that works in healthcare, not even just the clinicians, but if you work in IT, you're an administrator, you are in healthcare, and you've heard of safety and quality, God willing, please, hopefully that's everybody. And then finally, just to get the rest of the group, if you're a patient or you know a patient, and let me tell you, we're all at risk of being a patient. Okay, with that in mind, hopefully everybody had a chance if you were interested in standing up and stretching, and we helped our health, and we also just got a sense. And the main point I wanted to make about this is, safety and quality is sort of everywhere. It's not in enough places in our healthcare system, but it is in a lot of places. Before I get started, though, let me just take the opportunity to thank Michael in particular and your full team and Penn State Health for hosting us. Obviously, our meeting sponsors that Michael mentioned. I want to shout out to Michael in particular. As he mentioned, we've known each other for about 10 years. I think the mark of a good leader is knowing your team. I'm part of his team. He mentioned the summit that we've had over the last 2 days, which has been fabulous. I'd love to talk to anybody offline about what we're learning and sharing there. But again, the mark of a good leader is knowing your team. The stuff that I'm going to talk about is probably the easiest and simplest content that you'll hear about in the full time that you're here. Having said that, it's also the hardest to actually accomplish. So when you think back to what Dr. Pearl was talking about, that this is both a meeting about the AI and this tremendous technology explosion that's happening and sorting all that out. It really doesn't have a lot of effect unless appropriate actions are taken based on that information. That really is one big part of what healthcare safety and quality is all about. And in particular, with the focus on human factors, this is kind of the dream slot, if you will, for me on the presentation, because we got to hear from visionary leader Dr. Pearl. Dr. Parker told us about, I'll confess, of all the topics that I was responsible for when I was at AHRQ, human factors, and I liked simulation too. I sort of consider that a close cousin, if not part of the field of human factors. That really was my favorite, and I can tell you I don't say that about all the topics, So healthcare-associated infections, we got a lot of money for healthcare-associated infections. When I was at AHRQ, it was the best funded section. I like that, topic too, but human factors was really kind of, near and dear to my heart. Part of it is because we all live it every day, even if we don't know it by that topic. In fact, let me just take the opportunity to talk about a non-medical experience. So I drive a Honda pickup truck. That's my, daily transportation. Think about, most of us probably drive. Think about where the windshield wiper control is. This is really, I'm geeking out here, so bear with me. We got to talk about human factors a little bit. And just, if you can imagine, where the windshield wiper control is. My wife, her primary car is a Volkswagen SUV. That's just what she drives. I have the occasion to drive both cars, sometimes. The windshield wiper controls on both cars, it's in the same location, thank you. It's a right stalk, just behind the steering wheel. So imagine you're holding the steering wheel, it's your right hand, and it's a stalk, a lever that sticks out of the side, right, of the steering wheel. If I want to make the windshield wiper go faster on my car, I can tell you right now I don't remember. It's either up or down, because I know the other car is exactly the opposite. And so some of us might say, so what, right? I mean, who really cares? If you get it wrong, you just go in the other direction. And usually that is the case. But if I really need the windshield wipers and I need them to go faster so that I can see the car or the whatever I don't want to hit in front of me, and if you know James Reason's philosophy and the Swiss cheese model, and if things line up, and if at that split second that I need to see, I'm delayed by being in the wrong car and moving that lever in the wrong direction, I could have an accident. I could hurt somebody. I could hurt myself. That same kind of situation exists in healthcare still today. And if, as we parachute and drop in AI to help solve these problems, and I am a believer, I think I love Dr. Parker's point about, I'm not a human factors and engineering expert, by the way, but I'm a groupie, and sort of being at this meeting is part of that. But if, we really have to make sure that we get it right. It's not a negative perception. It's negative about what could happen. It's not negative about the technology. So keep that in mind, if you will. So with that, thank you again for indulging me on the little experiment with standing up. Factors. Oh, there we go. Okay. Again, I said I've got the simplest presentation. I'm going to live up to that. My main agenda, my main observation is similar to, I think, what Sarah talked about, and that is that, with expanded use of AI in healthcare, we run the risk of amplifying risks and unintended costs, waste, if you will, of not paying enough attention to healthcare safety, quality, and value principles, things that we've learned as this will be a trip down memory lane for most of us with the expertise that's in the room and safety and quality. But we're not exchanging those, well-tested principles and that knowledge for AI. These really do, it is a both and proposition. And I think in particular, human factors expertise is an area to focus on, in a really substantial way. So just go through some foundations, again, remind us all about some of the basics for healthcare quality. I think since, analysis is so central to the technology of AI, I want to just touch on that for a second. I want to talk about some specific topic areas. Diagnostic excellence, diagnostic safety and quality has been mentioned. I want to dig into that and consider that for a second, and then just wrap up with, kind of the way forward. So the title of the talk that was sort of given to me, and sorry, I missed my point that I said it about, I really do have the easiest job as far as content base. So value is sort of the request that I talk about. This equation is trying to drive a lot of healthcare. I say trying because, as Dr. Pearl already, reminded us, we're really trying to shift from volume to value. And all of the complexity that is involved in that is the day-to-day work of most people who are in safety and quality right now. This is a simplified, it's a deceptively simple equation. As we'll talk about, building out what does quality actually mean, cost to whom, savings for whom. Again, it's a simple equation, and I think it is helpful to think about it simply, but actually gets pretty complicated. And so when we're talking about change, desired change in this case, really there are only two ways we can increase quality, and that's by increasing value, by increasing quality while maintaining costs, or reducing costs while maintaining quality. So I think that simple reminder, as we think about AI entering a system that's already cost constrained in many ways, we have to, that has a lot of implications for how that works. So this is old stuff, right? I mean, is everybody in the room familiar with the 6 domains of quality? I'm just gonna stick with me here. So I'm surprised, and I've been surprised, regularly, how much we sort of stray away from these, and the complexity. It's understandable to me why it happens. The complexity of healthcare pulls us away from the basics. So when we're evaluating any new technology, and I don't think that AI is an exception, these actually are pretty durable. They're relevant, and if you find yourself sort of in this sea of uncertainty and confusion and novelty, I think coming back to these is actually pretty instructive, right? The other thing I would mention too is it's a simple list, the way it is up on the screen. One of the things that we talked about a bit in the summit over the last couple of days is these don't exist in isolation, and there are often trade-offs that need to happen in healthcare. Now, in some cases, we address those trade-offs in a very explicit way, and we know about them, but in other cases, the trade-offs are sort of below the surface, and they're not explicit decisions. And so, for example, we may trade timeliness for safety, but we may do that without understanding the implications of that. I think human factors and just safety and quality in general, those disciplines and that way of thinking will help us evaluate, is AI really helping us achieve high quality care, according to this tried and true definition. Okay. In terms of just timeline, the 6 domain, the Crossing the Quality Chasm was published in 2001, just to remind everybody. So hard to believe for me that it's been that long. More recently, those same principles have been updated, or I sort of think about it as made, that they've been made more active in different kind of reductions or revisions of sort of how we think about safety and quality. The triple aim we probably all know about, and then that evolved into the quintuple aim, which essentially added the focus on equity and the focus on provider well-being. One story that I didn't plan to talk about, but we've got a little bit of extra time. One of the great honors I had just before COVID started was to lead a project called the National Action Plan for Patient Safety. This was an Institute for Healthcare Improvement-led effort, and basically we pulled together kind of the knowledge that had been generated across the patient safety field, and we wanted to make it more active and sort of make it more accessible to a lot of folks. And one of the debates we had as we were organizing that information was whether clinician safety should be combined with patient safety, right? This idea of, how related are those? Now, mind you, this is right before the COVID pandemic, and sort of we made the decision well before the pandemic that, these really needed to go together. And, of course, that very dramatic, series of events that happened absolutely confirmed, that combination. So I think this evolution to, is sort of a major change in the patient safety field, but I think, fully appropriate. But one of the things that I think the triple aim and the quintuple aim has tried to do is, again, to make this more active in terms of, integrating safety and quality into day-to-day work. Okay, let me just keep moving. Again, this is trip down memory lane. So there's a lot that I could have talked about, today, but in particular with the focus on AI, I think, another series of work around quality that came from the National Academy of Medicine was this concept of a learning health system. I don't think it necessarily got wide traction outside of the healthcare quality and safety world as much as it is. Some of it is probably because of labeling. This sounds like it's something about education, but it really is correctly named. This is about the system learning based on the operation of the system itself. So it's very much, I think, connected to AI and what AI is trying to do in a more automated way in some cases, but the overall goal is the same: to put knowledge into the system and have operations informing what we do and ultimately improving what we do. So I wanted to mention that. And then just another kind of depiction of learning health systems. This is from my former agency, the Agency for Healthcare Research and Quality, to kind of put this in a graphical form. And I think it's really, and I wasn't responsible for this work, so I can make this compliment to say that, I think it correctly associates this, virtuous cycle that we want to create in healthcare of practice that is, of course, creating a lot of data, and with sort of a robust research environment, combined with the data, creating evidence that's informing practice, and ultimately over time, that's a reinforcing cycle that positively, improves what we do. And I think that vision and considering AI bolstering this and essentially power charging it is one vision that helps for me. In the patient safety world in particular, this is something, I'll just make a quick point here, that as we apply the learning health system model to patient safety, one of the things to think about, what is the actual work of patient safety? What are we talking about? How do you organize that field? And I want to just focus your attention on kind of the center of this outline. When we talk about practice for patient safety, one of the ways we sort of oriented our program is there are very technical aspects of care that are important. For example, with HAI prevention, there's a need to use the right kind of antiseptic on the skin to prevent a central line infection. That's a technical issue. Obviously, having that available in the work environment, that becomes more of a human factor, but it's technical around and associated with the specific adverse event. In addition to that, what is historically not so well appreciated are what I label here as these foundational factors. And those are things that generally cut across a lot of different kinds of patient safety events. They're relevant to many different problems. And so essentially researchers discovered this over time that, just culture was its own topic in general, but we proved time and time again that you can get all of the technical things right to prevent a patient safety event, for example, but if the culture is not right, you're probably not going to achieve, the kind of safety that you really want to achieve for an organization. So just culture is in that category. Team-based care and coordination. Whoops. I don't think I did that, so he's telling me, wait a second. So this concept, though, of, go back to this one, just finish this point. This concept that, the set of work, at least conceptually and then ultimately practically, can be divided into two categories, and focusing on the technical and kind of these foundational, almost contextual factors about the organization and the people working in it. So let's just keep that in mind as we kind of go a little bit more in depth. So another so I'm just hitting the highlights of I think safety and quality principles and areas of knowledge that are, I think, particularly relevant to artificial intelligence and implementation. Another kind of trend that emerged that I actually got very excited about as it happened, as someone who was responsible for advancing not only patient safety research, but getting that knowledge into practice. One of the problems that existed and still exists, although I think it's improving, is the fact that this body of knowledge doesn't have as recognizable and substantial a home within healthcare, within universities, within medical schools, et cetera. And so I think the AMA, to their credit, recognized this kind of emerging knowledge base and the need for a clearer home, kind of a shed, if you will, to put all these tools in, and ultimately from that basis, an opportunity to actually get the knowledge into early learners, so that when they finally get out into practice, they've got both the theoretical and a practical basis. So this concept of health system science emerged, and it was very practically oriented. I think it grew out of again, recognition of the knowledge base, and also the fact that physicians of the future, of today, really need to understand this collection of disciplines, including safety, quality, value. I think human factors is definitely in there. The socio technical aspects of healthcare, as well as things that are important to equity, and so on and so on. So, and then the thing that really got my attention is not only was this important, but it's as important as the other more traditional pillars in medical education. So basic science and clinical science. I finished medical school in 1995, just to put it into perspective. This was not really on the radar. So my medical school really had two main circles, of knowledge, and it was solid. It was, a good education. But I think in retrospect, we all can appreciate it was incomplete in terms of what's really needed to advance healthcare and advance health. So I think that's, again, a very good development. And just to build on this a bit more, one of the key factors in this health system science body of knowledge is systems thinking and understanding systems as a whole, including recognizing how all the individual parts need to work together to actually achieve intended objectives, and then making it very independent for an individual practitioner, or making it sort of very personal, if you will, to their experience, understanding how they're fill in the blank here. It could be their practice, whatever their role is, their practice, their clinic, if they're working in a health plan or a hospital, that's part of a larger interrelated system. And it's only really creating value in healthcare if that individual is thinking about how their work connects to the work of others in the healthcare system, ultimately to serve patients and populations. This idea number 3, I think, is essentially the human factors representation, how to improve individual program and system performance, in particular focusing on the individual. Dynamic thinking. A problem is not just a point in time. Healthcare is not just transactional. It's an evolution of a patient's status, et cetera. So all these concepts, I think, becoming more prevalent. I mentioned patient safety culture as one of those foundational factors for patient safety. One of the things that we can all be proud of in healthcare is the fact that we all know that we're compared in healthcare to other high-risk industries. Aviation, nuclear power was already mentioned. Just a side personal note, I've told some folks here. So my son is actually training to be a pilot. He's down in Pensacola, Florida, getting ready to start his Navy training. And so I think the history of human factors that Sarah mentioned is pretty personal to my wife and me right now, as we look at our son being put into these really interesting and exciting machines, but also really dangerous without heavy focus on human factors. So the point is, these other industries realized this long before healthcare did. We had a bit of a leapfrog effect, though, in one area, and that's on the ability to measure patient safety culture. In spite of us being behind on recognizing that, some really forward-thinking folks in safety and quality recognize the need to not only talk about culture like I'm doing now, in sort of a fuzzy way, but to recognize it as something that can be measured, quantified, and actually changed, right? You can actually influence culture, and the fact that we need to do that, not just because it's the right thing to do, but it's the effective thing to do, right? And so one of the things that our agency did, and I can't claim credit for this, I maintained and evolved these surveys, but they were already in existence, but we really kind of blew them out, and they're commonplace now in the field. But in healthcare, compared to some other industries, again, we can measure, manage, control, and improve patient safety culture. So, and you can see the components of culture, and in particular, some of these I think are going to be more and more relevant for AI. One final note on the patient safety culture surveys: as we continue to advance and develop those, there are supplemental item sets that were created. One for the patient safety culture survey is the health information technology survey. It would be really nice if health information technology implementation in healthcare went perfectly. I don't know if that's ever happened, but the point is recognition that, bringing together complex technology like that into an already complex system, the fact that culture is important and how receptive, an organization is to that big change, and most importantly, how successful they are in actually solving problems, working through those, and again, creating better quality systems. Okay, jumping around a little bit more, I think this just some acknowledgement of this continuum of data analytics that already exists in healthcare, and sort of as we think about AI, entering the mix, and we're trying to pull that in a more productive way. Where are we at right now, and where will different AI applications fit on this kind of continuum of data analytics? I think one way people may think about this is we're constantly trying to move to the upper right. These are things that are more difficult, but ultimately they'll have more value when we actually can not only know what's going to happen, but influence and control what's going to happen. That's really what, where we want to get to. Having said that, I don't think that the sort of lower left parts of this graph are going to become unimportant. There will still be maybe not so sexy, not so complicated, but still very, oh, I'm sorry, excuse me, thank you for the, I didn't go ahead, did I not? I'm clicking it on my screen. Now you can see what I'm talking about, continuum of data analytics. Yeah, this is a good test. Are my words helping, or is it really just, look at the screen? So again, this concept of data analytics, thank you for the help on the front. Again, the main point I think to take away from this is, we're going to continue to need analytic activity in healthcare that's at multiple points along the spectrum. And I think, human factors probably will, and other disciplines will help us think about where we want to be, what are we actually doing, what's the level of complexity and the cost, quite frankly, that we need to build in to perform, these different tasks. All right, remember to do this twice now. Just want to mention briefly, we actually, this came up in our summit discussion too, and I remember the first time I was exposed to this hype cycle, and sort of it helped me understand, and working in the innovation field with almost a flood of new things to pay attention to, how do you figure out which ones are most important? Where are we at? I think Sarah was talking about, did the development phase already happen? Was it yesterday? Was it just in the last hour? Was it 2 weeks ago? Just this kind of conceptualization of progress, and what is interest like? And as you really personalize this, what should my interest in my role be? I think it's hopefully pretty clear, based on this selected group, that we are high on artificial intelligence and the role that it's going to play. But when that's going to happen, and when we need to pay attention to specific things, I think thinking about the hype cycle, will probably help you do that. I love the labels on these different, inflection points. The peak of exaggerated expectations. I think, unfortunately, in healthcare, we live a lot in the trough of disillusionment. That there are so many innovations, and I'll say in my prior role, that was, and frankly, the role of, I think, forward-thinking health plans in general is to serve as, a filter, if things are working well, a positive filter to sort out, which things are actually not just novelty, but are actually true innovations that will make a difference. And as you think about that question, I personally think back to 6 domains of quality. So I think, the foundations really are helpful in my opinion. All right, let me get us moving here. We're gonna, start to wind down, but do that with a couple of examples. Mark is right here in the front. Dr. Mark Graber, who was already mentioned. Mark and a handful of other colleagues, really did us all as patients and humans a service by trying to bring this topic of diagnostic error, into the fold, to have it be better appreciated and recognized, not only within healthcare safety and quality, but I'd say more broadly within healthcare generally. And there's some interesting features that, Mark and other leaders in the field have helped us understand as we've, pulled this focus of improvement into our attention. Compared to other types of medical error, diagnosis really was underappreciated. Thankfully, that's changing, again, with lots of hard work, lots of attention to sort of making the case, and frankly, research helping to document how significant this problem is. There's been a lot of good work to actually count how bad diagnostic error is. I think there's more work to be done there, but there's enough to act, and I think that action's starting to happen, thankfully. Some of the estimates are quite high, and I think those may be underestimates depending on how we define diagnostic error specifically, but 5 to 20% or more, we just get it wrong. Healthcare gets it wrong. And when you think about the consequences of getting an early stage activity in healthcare on which a lot of downstream things will happen, in some cases, high stakes decisions and care like chemotherapy, whatever. I mean, things that actually will change the course of a patient's life, could cause lots of trouble. We just need to get the diagnosis right. I think we all appreciate that. This is almost too obvious. I think that's one of the reasons that it's evaded attention and improvement. But again, it's moving, we're doing better. This is just, sort of recognizing, graphically, how big the problem is, 1 in 20 people. And the other point I want to make, this is a graphic that we made when I was at AHRQ. We think about safety in isolation and these individual errors that happen. The reality of healthcare is it's all happening together at the same time. A lot of diagnostic error is also happening in the outpatient environment. So you see, along with diagnostic error, we have, medication errors, poor communication between clinicians and patients. And so I think these are the things that really conspire and combine to give us the results that Dr. Pearl talked about, where we're really just not doing what we should be doing, especially relative to the costs that are being poured into healthcare. So the National Academy of Medicine, again, is responsible for this work, and I think the definition is important to highlight, and it's really twofold. I want to make sure that people come away with this recognition. It's not only getting the diagnosis right and being accurate and timely in that diagnosis. Again, you can see the influence of those domains of healthcare quality, so they keep serving us over and over again with new problems, so it's pretty foundational knowledge. But in addition to getting the diagnosis right and having it be timely, that also has to be communicated effectively to a patient. And that's a pretty high bar that the National Academy said that it's an error even if you get it right, but the patient doesn't necessarily fully understand, isn't communicated well. So I think it's fully reflecting the importance of patient-centeredness and kind of, again, being true to those 6 domains. I think we've talked about most of these things, the difficulty in measurement. I think, it's a true systems problem, and the bottom bullet here sort of talks about how, who owns the problem and kind of this diffusion of responsibility that happens. It's a classic safety and quality issue, a classic, human factors issue. And so, again, this knowledge base is going to continue to be relevant as we move into the era of AI. This is the kind of graphic that depicts the diagnostic process, also in the National Academy of Medicine's report. One sort of point, I've seen lots of graphics, having been in government, things like this that are sort of trying to pull us all around, the model for getting everybody together. Anytime you see a circle in a graphic like this, beware. That's again, I told you this would be a basic kind of, basic talk. So, and it's not a criticism of the graphic. I think it's very accurate, but the point is, and the way you should start to think about this, and the way the way we need to think about it when we're unleashing AI on this is, it's a bit of a black box, a circle in this case, about what happens. Now, so that's potentially, back to Sarah's point again, it's ideal to follow her. Human factors and quality and safety people, we're not negative, we're just realistic, and we've seen it time and time again. And so what does that mean for us in terms of what we should do? How can we act? And what makes me hopeful? I think we have an opportunity as we implement AI to actually not only let AI fix the problem, but actually to look more fundamentally at the problem itself. And so I think the revolution in AI will not only be about exposing us to AI, but actually it's going to push us, encourage us to redesign care itself in many ways. In fact, it's going to be necessary, I think, to fully implement and get the benefits of AI. Start to wrap up here on just another quick, kind of more focal issue that has just consumed a lot of resources in the field, and that's measuring and tracking patient harm. What you see here, it's been a persistent problem and challenge, and how many of us, whether you stood up in the first group and you're all about safety and quality that I asked about, or you were in the last group, that touches it, regularly, but it's not central to your work. When you've embarked and been involved in a patient safety and quality project, we have to measure, right? I mean, that's it's always in the mix. And how many of you have had the experience of working on that project, and by the time the measurements set up, you have the data to inform the work, everybody's just exhausted. There's no more time left on the calendar. The project period has already, it's just been, measurement has been a bear. It's consumed all of the work, all the resources in the room. My hope is that this is a clear place where AI can actually help, but obviously trust is going to be important too. So, consider the transition that we're in. We're probably going to need to be operating our legacy, clunky, expensive, imperfect measurement systems to validate to a certain level, our AI processes. But I think after we have confidence, we can move forward. This is, again, measuring patient safety at a national level. It was a pretty big undertaking. Interestingly enough, it probably happened the way it should happen, where when a big injection of money on the order of a couple $100 million came with the ACA through CMS to improve safety, people had the good sense to say, we really need to be able to measure what's happening at a national level. How can we do that? Everybody in the field looked around, and we actually did not have good measurement systems at a national level. We had an okay measurement system, so we beefed that up to great expense. But the other thing I would say too is we should think about pulling the knowledge from not only this kind of system or these kinds of systems, but other similar systems, because there is a lot of knowledge represented, even if they're imperfect. smart people have gone through and thought about what needs to be measured. And although AI may not measure it the same way with exactly the same methods, there is still knowledge to be gained. And I think that's the smart play, is to sort of build on what's been done, not be constrained by it, but apply it in that way. Just another big undertaking. Some of the most attention that my program received while I was at ARC is when we put dollars. We put the cost of patient safety, and we put the cost not only on dollars but lives. This was a huge challenge, with appropriately so, in the research world. How valid were these numbers? Lots of discussion about that. But we really do have to really get the value. We have to do this hard work and consider the precision that we need, and in some cases the precision that we don't need, because obviously precision has a cost too. And thankfully we did achieve overall reductions nationally. When I say we, I mean everybody who was working on patient safety nationally. An overall 13% reduction in that period, 2014 to 2017. And again, 20,000 deaths we think were averted, and 7.7 billion, real money was saved by these estimates. Last thing on this topic is, I talked about the knowledge in the existing systems. One of the things we did is we recognized the expense and just the burden of measuring something like patient safety at a national level, and AI was definitely starting to become more in people's awareness, and so we commissioned a report to actually dig into what are the concepts that need to be translated. What are they actually doing when they do chart abstraction and chart review? That's the method that was being used at the time. And can AI really do that? So this is just a representation, just within the topic of patient safety, of what AI really has to be able to do to sort of represent and measure these concepts that we care about. So one example, just it's the second from the bottom, what the experts labeled as fuzzy concepts. This concept of, which was part of the measure, this is something that humans said we care about when this happens. Did a patient undergo an unplanned transfer to a higher level of care area within the facility or to another facility? Obviously we care about that. Something's happening, it's an action, it's an important event, but a human and their experience and expertise to be able to evaluate whether something was planned or unplanned, it's a pretty sophisticated, as it says here, fuzzy concept, lots of judgment involved. And so the AI experts in the room, can tell us, where are we at on the ability to sort those things out and to reliably tell us what we need to know, in a more efficient way. And then the final thing is, this problem is by no means solved. One of the things, you have to listen to me for maybe 5 or 10 extra minutes. It's already done, but because David Bates couldn't be here, David is, a world leader in the field of patient safety. This is some work that he did that I told him I'd be representing today on his behalf. But the simple point to make is, just within the area of patient safety, and there are many more areas like this throughout healthcare, but just in patient safety, there's a lot of waste, a lot of potential value that can be extracted from the system if we can efficiently apply AI to go find these problems and ultimately to fix them. Again, if our systems are able to act accordingly and use the information. Okay, just to wrap up then, it's probably pretty clear that I think although I'm high on the potential for AI, there's definitely a need for caution. But I think a safer way forward is to just recognize, and this will actually propel us forward, the human and financial costs when we don't get quality right, including waste that's in healthcare. There really is a lot of potential there, and we really want to tap it and try to extract that value. But in order to do that, we absolutely have to respect and draw from these foundational knowledge points and principles that healthcare quality kind of represents. And if we don't engage experts early and often, in particular with human factors engineering, quality safety, and as Dr. Pearl so aptly mentioned patients, the knowledge that patients have. They are really the one constant throughout the system, and I think the patient safety and quality world has increasingly recognized that the information, knowledge, the perception that patients have, and empowering patients to not only see and tell us more, but to contribute to their health in more meaningful ways, that's huge. And then I think, again, when you really boil it down and amidst all this complexity, we're trying to find the things that really are solutions, that are true innovations, and that's in a sea where there is quite a bit of novelty, right? There is so much money in healthcare that many people are, I think, legitimately trying to solve problems, but in many cases they're just adding to the problem with more complexity that's not really innovating, on healthcare and what we need. So obviously talking to the right people early on will help prevent harm and get us moving in the right direction. Final thing, this is, I hadn't really followed this person, not being an expert in AI, but I think someone recognized as the godmother of AI. Thanks to Mike for sharing this piece, this interview with this leader, and these were just really compelling quotes that our values really are represented. Doggone it! Thank you. This is thank this gentleman here for his help. These are those quotes that I was just talking about. Fei Li, godmother of AI. Thank you again. So these tools are just tools, right? They are incredibly interesting and capable tools, but they are just tools. So our values are reflected in them and how we use them. There's also, I think the second point really aligns with both Dr. Parker's talk and the points I've tried to reinforce, that there's absolutely potential for increased productivity, but is that really making us more prosperous? Is it helping? Is it achieving the 6 domains of quality, advancing those? And then I think we definitely also need to recognize that there's an equity issue here, that equal access or to the technology is critically important. And then just to finally wrap up, on a totally human point, when asked whether there are aspects of human intelligence that will always be beyond the capabilities of AI, I think the clear answer was compassion and love. I will say, as an aside, AI can help on those too. So patient engagement and reminding providers, especially when they're tired, especially when they're busy and they're distracted by technical things, that there are compassionate things that they not only can do but should do to actually improve care. Patients are going to be more responsive. So even on the exception that I think Dr. Lee talks about, I think there's potential for AI to be an improvement there too. Thank you for your time and attention, and also thank you for all the work that you're doing to improve healthcare.